Okay, thank you very much, Mrs. Chairman, Sabrina, and good afternoon, everybody. So we'll move on a little bit more posteriorly in the skull base, and I will talk about the middle cranial fossa. So the problem with the skull base is that it's a hidden area for clinical examination. So patients that have lesions in the central skull base, the clinical symptoms and signs are either very scarce or non-specific. Imaging is therefore very important in the detection and in the prediction of the identity of skull-base lesions according to their site of origin, their pattern of growth, and their tissue characteristics, as well as in the definition of the lesion extent. And this allows treatment planning and treatment choice, mainly anticipating the morbidity of surgical procedures and also in the delineation of the targets for radiation therapy. So if one looks at the skull base from above, you can immediately recognize the middle cranial fossa, which is here. The floor of the middle cranial fossa is made by the central skull base, and the central skull base is separated from the anterior skull base by a line that passes through the chiasmatic sulcus by the anterior clinoid processes, the posterior margin of the lesser sphenoid wings, and then the anterior and superior rim of the greater sphenoid wings. Posteriorly, it is separated from the posterior skull base by the spheno-occipital synchondrosis, then by the petroclival fissure and the superior ridge of the petrous bone. Sorry. The central skull base is made medially by the body of the sphenoid, which houses the sphenoid sinus, and a little bit more posteriorly by the basisphenoid or anterior aspect of the clivus. More laterally, you have the greater sphenoid wings, and then the central skull base is pursed by a variety of neurovascular foramina. So, as I told you, the chiasmatic groove separates the anterior from the central skull base. It is a linear depression oriented in the transverse plane in the planum sphenoidale, and it is made by the optic chiasm. Immediately anteriorly and laterally to the optic chiasm, you have the optic canal, and this optic canal gives way to the optic nerve and to the ophthalmic artery. A little bit more inferior and laterally, you can see the superior orbital fissure, and this fissure gives passage to cranial nerves 3, 4, 5, 1, 6, and the superior orbital vein. Moving a little bit more downward, you get to this canal, which is the foramen rotundum, which is actually a canal. And this gives way to the maxillary division of the trigeminal nerve, 5-2, and it has an endocranial opening in the most inferior aspect of the cavernous sinus and goes all the way anteriorly to open in the pterygopalatine fossa. Then you have its terminal branch, the inferior orbital nerve, which crosses along the back wall of the maxillary sinus to enter the inferior orbital fissure. If you move a little bit more medially and inferiorly, you will get into another canal, which is the Vidian canal. This canal gives passage to the Vidian nerve, and the Vidian canal has its posterior opening in the region of foramen lacerum, and then extends all the way anteriorly to the high pterygopalatine fossa. Then if you move a little bit more laterally, you have another foramen, which is foramen ovale, and this gives way to the nerve 5-3, or the mandibular division of the trigeminal nerve. If you want to look at the cranial-caudate relationship between these canals, you see the optic canal more superiorly with the optic nerve inside, then a little bit more inferior laterally to the body of the sphenoid, you see the foramen rotundum giving way to V2 or 5-2, and then a little bit more inferior and medially at the base of the pterygoid plates, you see the Vidian canal with the Vidian nerve. More laterally, you see foramen ovale, which gives way to 5-3, the mandibular division of the trigeminal nerve, coursing from the Meckel's cave to the mastigator space. So the problem with skull-base lesions is that not only they can arise from the bony cartilaginous elements of the skull base proper, but they can also arise from the intracranial compartment or from the exocranial head and neck, as well as from systemic conditions. So we have to consider a lot of different differential diagnoses. Also, aggressive lesions may cross the skull base by destroying bone or the fissures, or they can cross through the neurovascular foramina of the skull base. So we have two main crossroads between the intra- and extracranial compartments, the cavernous sinus and the pterygopalatine fossa. The cavernous sinuses are dural-based sinuses. They are paired structures lying on each side of the sphenoid body. They receive venous drainage from the ophthalmic veins and sphenoparietal sinuses, and they drain to the superior and inferior petrosal sinuses. The pterygopalatine fossa lies extracranially. It has this shape of an inverted pyramid. It goes all the way from the inferior orbital fissure down into the palatine foramen that open in the posterior oral cavity, and it houses the sphenopalatine ganglion, the branches of the 5-2, and also the internal maxillary artery together with some fat. So the cavernous sinus normally measures around 12 by 6 by 6 millimeters, and in normal conditions, its lateral contour facing the mesial temporal lobe should be concave. You can recognize inside the cavernous sinus, in the lateral wall, which is also called the ocular motor trigone, the cranial nerves that I told you before. So on MR, contrast-enhanced MR, you feel the sinus, the dural sinus with contrast, and you can depict clearly the cranial nerves. So the most superior one will be cranial nerve 3, then the small one is cranial nerve 4, and then you have 5-1 and 5-2 that can be clearly appreciated on MR. More medially, you have the carotid, the cavernous carotid trigone, which contains the cavernous carotid artery and the single thoroughly intracavernous cranial nerve, which is the cranial nerve 6 or the abducens nerve. The cavernous sinus communicates with the extracranial compartment anteriorly and superiorly with the orbit by the superior orbital fissure, and a little bit more inferiorly and also anteriorly with the inferior orbital, with the high pterygopalatine fossa through foramen rotundum. The pterygopalatine fossa, as I told you before, can be very well appreciated on sagittal MR images. It has this shape of the inverted pyramid going from the inferior orbital fissure to the palatine canals in the posterior aspect of the oral cavity. And as I told you before, it contains the sphenopalatine ganglion V2 and the branches of the internal maxillary artery. The pterygopalatine fossa is a crossroad, so it has a lot of different connections, anteriorly and inferiorly with the inferior orbital fissure, posteriorly with the cavernous sinus through foramen rotundum, a little bit more inferiorly and posteriorly with the petrous carotid canal through the Vidian canal and the Vidian nerve, inferiorly, as I told you, with the posterior oral cavity by the palatine foramen, then medially with the posterior nasal cavity through the sphenopalatine foramen, and laterally with the infratemporal fossa or masticator space through the pterygomaxillary fissure. Here in the coronal plane, you can actually appreciate the greater and lesser palatine nerves opening in the oral cavity. So how do we image the skull base? Ideally, we should perform a full contrast-enhanced MR and a CT using only high-resolution bone algorithms. So you get a volume acquisition on CT, reconstruct the images at 1 or 2 millimeters at the most in the axial, coronal, and sagittal planes. And then why is this important? Because it provides a roadmap of the bony anatomy, which is useful for surgery and for radiation treatment planning. And CT is considered by some more specific to the diagnosis of some bone lesions and fibroosseous conditions. On MR, we should acquire sagittal, axial, and coronal T1 and T2 weighted images. I usually perform axial and coronal stir also. 3D heavily T2 weighted images whenever you need to look at the cranial nerves crossing the cisterns, and 3D contrast-enhanced fat-suppressed T1 weighted images. As you know, MR has increased soft tissue resolution, and it is more sensitive to evaluate intraorbital, intracranial invasion, and perineural spread of disease. In order to make differential diagnosis easier, we should separate the central skull base into 3 different compartments. A medial compartment that lies medial to the petroclival fissure, then a parasagittal compartment that lies between the petroclival fissure and the lateral margin of the foramen ovale, and then the lateral central skull base, which lies lateral to this line. So beginning with the midline sagittal central skull base, in order to make differential diagnosis, you need to know exactly what lies in there. So we have the body of the sphenoid containing the sphenoid sinus, and you have the clivus also. Then above you have the pituitary gland and the sella turcica, and below you have the nasopharyngeal mucosal space. So what kinds of lesions can we get there? We can get lesions arising from above, from the sella turcica, mainly pituitary lesions, or lesions arising from the pharyngoepiphyseal tract or pouch. Then we have intrinsic lesions coming from the sphenoid body, which are primary or secondary bone tumors. We may have lesions in the clivus, mainly chordomas, and arising from the sphenoid sinus, squamous cell carcinoma, for instance, which is rare in this location. Lesions from below will arise from the nasopharynx, mainly tumors or infection. So, beginning with a lesion in the central sagittal skull base is chordoma. Chordoma is a tumor that arises from remnants of notochord that get entrapped into the clivus during embryologic development. You see this soft tissue lesion that is replacing the high signal intensity of the fatty marrow of the clivus, is expanding the clivus and has a permeative, aggressive bone destruction of the cortical margins of the clivus. Note the relationship of the lesion with the sella. You can see the pituitary gland here. These lesions typically are very heterogeneous on T2-weighted images because of the presence of bone that gets entrapped within the lesion, mucoid degeneration, and hemorrhage. After gadolinium, the typical pattern is this honeycombed pattern of contrast enhancement. Another similar lesion in the same location, the central sagittal skull base, is replacing the clivus, the body of the sphenoid, as well as the sphenoid sinus. But note in this case that the floor of the cell is displaced inferiorly, as well as the optic chiasm. We see no pituitary tissue inside the cella, and you see this leftward deviation of the pituitary stalk. This calls up your attention that the possibility of this being a lesion originating primarily from the pituitary gland, and this turned out to be an intraosseous adenoma of the pituitary gland. Another lesion, same location, a little bit more inferior, so you see that this lesion is actually inside the sphenoid sinus, expanding the bony walls. You see this remodeling and thinning of the bone, so this is a non-aggressive kind of remodeling of appearance. On MR, you see that the lesion is heterogeneous in signal intensity, mainly due to the presence of these voids of signal inside the lesion, and it does not enhance except for the mucosal lining of the sinus itself, and so this is very typical for a mucocele. In this case, the areas of signal void were due to fungal infection, so in this case, a mycetoma. Another lesion in the central skull base, this time arising from above. So this lesion is sitting in the sella turcica. It is displacing the floor of the cella inside the sphenoid sinus, and it could be macroadenoma. In this case, it turned out to be a craniopharyngioma, which is arising from the craniopharyngeal pouch. And the typical appearance of this lesion, they can be cystic, mixed, or solid, and often they have these marginal calcifications, which are best seen on CT, but that we can depict there as this small area of high signal intensity on T1. We can also have meningiomas arising from above. So this is a dural-based lesion in the plenum sphenoidale, which is growing through the diaphragma sella into the sella turcica and is compressing the pituitary tissue against the cellar floor. You can see that the lesion enhances homogeneously after gadolinium, and you can see the typical dural tail. Also note the sclerosis and the blistering of the sphenoid, giving this appearance of a dilated sphenoid sinus, a situation that is called pneumosinus dilatans. So moving a little bit more lateral, so we get into the parasagittal central skull base. What do we have here? We have the greater wing of the sphenoid with foraminal valley, and we have the petroclival synchondrosis. Above, we have the cavernous sinus, we have meninges, of course, and we have the mesial temporal lobe. Below, we have the nasopharyngeal mucosal space, and a little bit more laterally, the mastigator space. So what are the lesions that can arise from here? Those that are intrinsic, mostly arise either from bone or from the petroclival synchondrosis, and then you have to consider chondroid tumors. From above, mainly they arise from cavernous sinus or from the cranial nerves, so you have to consider vascular lesions and neural lesions. And from below, again, from the nasopharynx or mastigator space, consider tumors and infection mainly. So this is a lesion located in the parasagittal central skull base. You see that there is a replacement of the fatty bone marrow of the petrous apex and clivus, and this is sitting in the region where the sixth cranial nerve crosses from the posterior cranial fossa into the medial cranial fossa through the Rellus canal, and actually this patient presented first with diplopia. You see that the lesion is growing into the cavernous sinus. The lesion, one of the typical features of this lesion is the bright signal intensity on T2-weighted images, often brighter than the CSF itself. And another typical appearance that is not seen on this case but was seen in a different case shown here on CT are these typical chondroid-like calcifications. And this turned out to be a chondrosarcoma. As you have many neurovascular foramen in the central skull base, you have always to consider the possibility of a cranial nerve or a cranial nerve sheath tumor, and you have to know the course of cranial nerves in order to make the diagnosis of these lesions. So you see that this lesion is actually along the course of the trigeminal nerve, of the cisternal portion of the trigeminal nerve. Actually, it has a dumbbell shape. It has a posterior fossa component here in the lateral preponderant cistern, and then it has a middle cranial fossa component which is obliterating Meckel's cave, which can be seen on the normal side here, and the lesion has a small waist at the region of the porus trigeminus, which is the dural opening for the trigeminal nerve. Another kind of sausage-shaped lesion, which is growing from posteriorly from the region of foramen lacerum anteriorly to the pterygopalatine fossa. And you see that this lesion is kind of remodeling and expanding the Vidian canal, a situation that is best seen on the coronal sections. You see the enlarged Vidian canal displacing superiorly foramen rotundum, and in this case it turned out to be a neurofibroma of the Vidian nerve. Then you have to consider vascular lesions, and vascular lesions are those that you should not misdiagnose to avoid the consequences of a possible biopsy. So this is a giant cavernous carotid artery aneurysm. You can recognize that because you can no longer see the normal flow void of the cavernous carotid artery. You can see it on the other side. Here you see this secular lesion that is very heterogeneous with an eccentric flow void seen here. And you can, if you have any doubts, you can perform a MRA or a CT angiogram. This is a different patient, again, showing a large, giant cavernous carotid aneurysm, where you can see the enhancing portion corresponding to the patent lumen, the thrombosed area, and the atherosclerotic calcifications. Another vascular lesion that you may encounter here is the cavernous carotid fistula. Again, you see in this case abnormal signal voids inside the cavernous sinus that do not correspond to the internal, to the cavernous carotid artery that can be seen here. So it's surrounding the carotid artery itself. It expands the sinus. You can see the lateral bowing of the dural wall of the cavernous sinus, and you can see all this congestion of the ipsilateral orbit with thickening and enhancement of the extraocular muscles, as well as this obscuration of the fat. You can see on the other side slight dilatation of the superior ophthalmic vein, and in the MRA and the CTA corresponding to this patient, you see this flow-like enhancement, so this turned out to be a cavernous carotid artery fistula. Another lesion that you have to make the diagnosis to avoid a biopsy is a cephalocele. So here you can see a lesion in the mastigator space that abuts the parasagittal central skull base here. It has a solid component and a cystic component. And then if you look at the coronal images, it is very easy to see that there is bony dehiscence of the greater wing of the sphenoid in the region of foramen ovale, with herniation of the intracranial contents into the mastigator space. Both the inferior temporal gyrus and CSF are seen growing into the mastigator space. You can also find here meningiomas. This is a cavernous sinus meningioma. You see this homogeneous enhancing lesion filling in the cavernous sinus. Note the stenosis of the internal carotid artery, the cavernous carotid artery. The lesion is growing anteriorly into the superior orbital fissure, medially into the sphenoid sinus, and posteriorly is impinging upon the Meckel's cave. Incidentally, this patient had a second meningioma here in the CP angle cistern on the other side. So lesions arising from below, you have they can invade or cross the skull base either by direct extent or via perineural spread, and the most common lesions will arise from the nasopharynx, nasopharyngeal carcinoma or lymphoma, and from the mastigator space, consider infection, sarcoma, and particularly rhabdomyosarcoma in children. Here I show an example of a nasopharyngeal carcinoma. As you know, these lesions tend to occur in the lateral wall of the nasopharynx, arising from the fossa of Rosenmuller, and then they tend to invade the skull base superiorly against the foramen lacerum and the petroclival fissure, and from there they have easy access to the jugular foramen and to the condylar canal of the hypoglossal nerve. You can see this better on MR, where you see the replacement of the fatty marrow of the clivus and of the occipital condyle, and you see the lesion growing into the jugular foramen and into the condylar canal on the right side. Another lesion that may occur here is the juvenile nasopharyngeal angiofibroma, the JNA. This is a locally aggressive but non-malignant tumor, locally aggressive but does not metastasize. These tumors tend to occur in the region of the pterygopalatine fossa, and of course they tend to grow along the crossroads of the pterygopalatine fossa. So you see the anterior bulging of the posterior wall of the maxillary sinus, the pterygoid plates being pushed posteriorly, and the lesion is growing into the posterior nasal cavity through the sphenopalatine foramen, into the infratemporal fossa, through the pterygomaxillary fissure. Superiorly, it has gained access to the Vidian canal and to foramen rotundum, and is growing into the ipsilateral cavernous sinus. Of course, conventional angiography is only performed nowadays for preoperative embolization, and these tumors have arterial supply provided by the internal maxillary artery. Another thing you have to consider is perineural spread. This was a patient that had a squamous cell carcinoma, actually an indifferentiated carcinoma of the nasopharynx. He was treated with radiation and chemotherapy, and 5 years later he showed up with loss of sensation on the left face, and what you can see in the MR images is replacement of the fat in the pterygopalatine fossa. You see abnormal soft tissue going into the inferior orbital fissure, posterior along foramen rotundum into the cavernous sinus, and actually in these non-enhancing T1 weighted images you see the enlargement of the 5-2 and also of the Vidian nerve, and this corresponded to perineural spread of tumor. Now, finally, we're moving on to the lateral central skull base, so everything that is lateral to the foramen ovale. And here you may have lesions that arise from the greater wing of the sphenoid bone or from the temporomandibular joint. And here you may have tumors or tumor-like conditions. From above, of course, you have also to consider meningiomas, and from below you have the mastigator space lying more medially, so consider again infection or sarcomas, and you have the parotid space more laterally, so you have to consider salivary gland tumors or perineural spread along the cranial nerve 7, the facial nerve. Here I show you an example of a lesion that is related to the TMJ. You see this expansile lobulated lesion that is expanding and remodeling bone. You see the disappearance of the glenoid cavity, the anterior margin of the glenoid cavity. The lesion is slightly hyperdense on plain CT images, and you see that it is very heterogeneous on MR with these areas of void of signal and enhances in a frond-like pattern. We could not see any calcifications. It could be osteochondromatosis, but these turned out to be a pigmented villonodular synovitis. Another very rare tumor that you may encounter here, that is a tumor typical of teens because it appears only when the growth plates are still in place, are not closed. These turn out to be a chondroblastoma. These tumors are often subarticular. Of course, when they appear in the temporomandibular joint, this is quite rare. You see this sclerotic, the remodeling of bone. You see here the mandibular condyle here inside the lesion, and the cystic areas inside. Of course, we could not make the final diagnosis. This could also be an osteoblastoma, but it turned out to be a chondroblastoma. Sorry. So another thing you may consider, even an intrinsic lesion can be a meningioma. You may have meningocytes that get entrapped into the bone, and when you have meningocytes inside the bone and you have a meningioma, what happens is that this elicits a very strong osteoblastic reaction, and you see this sclerosis of bone. Of course, here the main differential diagnosis would be bony lesions and fibroosseous lesions or sclerotic metastasis, but these turn out to be intradiploic or unplaqued meningioma. I will not talk about the intrinsic skull-base lesions because we have a variety of bone tumors that may occur in any of these compartments of the skull base. The benign tumors, you have to consider osteomas and hemangiomas, which are the most common. In the malignant side, you have to consider metastasis in an adult patient. Just don't forget that when you see an infiltrating lesion in a sick patient that is ill and has infectious signs, consider the possibility of skull-base osteomyelitis. This was, particularly if the patient is immunocompromised, this was a diabetic patient. He had an external otitis before, a malignant otitis externa, and this is extensive destruction of the central skull base due to osteomyelitis. Note the encasement of the petrous and cavernous carotid arteries on both sides, and this is, of course, this patient ended up dying. This is a Pseudomonas infection that is very hard to cure. In HIV-positive patients or other immunocompromised patients, another thing you have to consider is invasive fungal infection, and this was a patient with HIV-positive with invasive mucormycosis. You see this lesion that is inside the maxillary sinus, ethmoid sinus, and nasal cavity, but it's transgressing bone. You see this abnormal soft tissue here in the pterygopalatine fossa, in the infratemporal fossa, as well as in the cavernous sinus, encasing the petrous and cavernous carotid artery. So, in conclusion, the central skull base can be involved by a variety of lesions. These lesions may arise from the skull base proper, from above or from below, or can be systemic, of course. You have to keep in mind that head and neck surgeons and radiation therapists have to rely on imaging for treatment planning because they have no access to visualize the skull base. And I hope I have convinced you that if you look at the exact location of the lesion, the site of origin, the pattern of growth and tissue characteristics, and also paying attention to the clinical findings and to the statistics, you can provide quite a good prediction to the final diagnosis. And I thank you very much for your attention.